Ms. Debra Duquette is a board-certified genetic counselor and national leader in implementation of precision public health and population-based screening approaches for hereditary cancers. She is the Associate Director of the Graduate Program in Genetic Counseling and an Associate Professor at Northwestern University Feinberg School of Medicine. Previously, Ms. Duquette served as the Michigan Department of Health and Human Services Project Manager and Director on 5 CDC Public Health Genomics Cooperative Agreements. She is the co-chair of the National Academy of Medicine Public Health Genomics Action Collaborative and the founder and chair of the Lynch Syndrome Screening Network. Ms. Duquette will present implementation of public health genomics and possible future dental applications. Please welcome Ms. Debra Duquette.
Thank you so much to the conference organizers for having me here this afternoon. It is my absolute pleasure to be here, and I'm going to be trying to cross a few different bridges together. One would be my genetic counseling clinical background, and number 2 would be my practitioner background in public health and working in a state public health department. Also, I can tell you that talking with public health folks, talking to genetics folks, I feel very comfortable with, but this is a brand new audience, is learning more about public health dental folks. So in the past month or so since I've been preparing this talk, I've learned an incredible amount about public health dentistry, and I think there is amazing opportunities for collaboration, and I'm so glad for that polling question because I think we're starting with a pretty low baseline, and I think we only have up to go. And I wish we could actually do that poll again, which I think we'll do maybe at the end, but in another year, because I hope in the next year that more than half of you will reach out to a genetic counselor close to you and learn more about what they might be able to work with as a collaborative partnerships with you all. And I do apologize. I realize I do this all the time in January. I'm still in last year. So on my slide, it's 2018. I know. Also, when I was preparing today's talk, I was channeling Bob Gorlin. And Bob, I don't know if anyone in this room knows Bob, but in the world of genetics, he is the go-to person that we always would think of when we were thinking especially about craniofacial abnormalities and thinking about clinical diagnoses based on craniofacial features. And Bob was a dentist by training. He was also at University of Minnesota and head of oral pathology, and he passed away in 2006, but he had published, and it was in its 5th edition when it came out after his death, Gorlin's Syndromes of the Head and Neck. And if you've never seen this book, it's a hard one to find. It took me a while to find it because, as it was mentioned, I just recently moved to Chicago. But it is a wonderful book to take a look through because it really does capture in amazing detail since the 1960s on to 2006 when the last edition was published, a multitude of genetic syndromes and has the very best features captured in photographs. So if you're not familiar with Gorlin's Syndromes of the Head and Neck, please try to take a look at that. And that might be a reason to reach out to your local genetic counselor or geneticist to see if they could have you take a look at that book. But just to let you know a little bit more about Bob, another famous geneticist whose name is Judy Hall captured it very nicely when he said that in human genetics, we think of Bob belongs to us in genetics, but the dentists, the pathologists, the dermatologists, the oncologists, the reconstructive surgeons, and the craniofacial specialists all think he belongs to them too. And it's with that kind of thinking that I think we need to go with what's happening with precision medicine and implementation, and that kind of thinking of individuals or multiple individuals coming together from multiple specialties. But Bob was a pretty unique person who brought together a multitude of specialties. And in fact, he described more than 100 different syndromes that include not only craniofacial genetic syndromes, but also conditions that are in oral pathology, also in obstetrics, and also in otolaryngology. There are a multitude of genetic conditions, a multitude with genetic implications. And it literally could be a 10-week course and we would not be able to get through all these genetic syndromes. So I'm going to focus mostly on today's talk about hereditary cancers and specifically colon cancer. But just to let you know that of the more than 5,500 known human genetic disorders, more than 700 are craniofacial disorders. And also we know that there's more than 200 genes involved in the embryonic development and morphogenesis and differentiation of the teeth. There are craniofacial abnormalities as well as oral anomalies as well as dental anomalies associated with not only chromosome abnormalities, but also a multitude of genetic syndromes. Also, we're learning much more about isolated non-syndromic causes of oral anomalies and dental anomalies. And then what I would like everyone to think about in their own work and research as well as in clinical practice, and this was also very much nicely articulated by the last speaker as well, is to think about dental phenotypes as this could be going on when we see something different as an isolated finding, or could it possibly be associated with a syndrome with much more broader implications? And so it's an important reason, and I hope to give you a couple examples to explain this, to think about family and medical history when we see something that looks different and going beyond just the oral features that you might be seeing, and to consider associations with other conditions, such as some of the things I'm going to show you today, to think about asking about family histories of cancer, especially colon cancers, breast cancers, thyroid cancers. Also, I would also encourage people to think about asking about specific genetic conditions, because there are a multitude of genetic conditions that can have very, very important implications in clinical dental practice as well. And also, I'm going to encourage everyone, which was the first polling question, to think about referring to a genetic counselor or other type of specialist when you feel like this could be possibly a genetic syndrome, or maybe I should need to double check about possible implications of this genetic syndrome in the dental setting. And I think that when possible, that a dentist, a public health dentist for sure, should be part of a personalized medicine team as well. And when I was doing some research on this, I came across an article from 2016. It said, I don't know if this has changed in the past year, but at that time it had stated that there was only one dental school in the United States that required a semester of molecular biology or genetics for admission. So I think there's a lot of a learning curve here that might need to happen in the dental school environment to catch up with what's been going on in the precision medicine world. So what is genetic counseling? It sounds like about 10% of you not only know what genetic counseling is, but have actually referred to a genetic counselor, so thank you to that. But genetic counseling, there are about 4,000 board-certified genetic counselors across the United States and actually in other countries as well. And there are over 50 now programs internationally that people can get trained in a master's degree in genetic counseling. But also genetic counselors can be geneticists with a PhD or an MD as well. And what happens in a genetic counseling session is that it's a process of actually trying to help people understand and adapt to the medical, psychosocial, and familial implications of genetic contributions to disease. And it typically involves a very, very careful interpretation of the family and medical histories to assess the chance of a disease, the occurrence of a disease, or recurrence of a disease. And also it includes education about inheritance, testing, management, prevention, resources, and research, and it promotes informed choices to the risks of a condition as well. And historically, when people think of genetic counselors, and this would be going from all the way till the genetic counseling started in the 1970s, early 1970s, all the way up until the late 1990s, people mostly thought of genetic counselors in one of two settings, either a prenatal setting with a high-risk pregnancy or in a pediatric setting with a child that had multiple anomalies going on that you were kind of trying to come up with a diagnosis. But then right around the year 2000, there became an explosion of information that we learned about cancer genetics. And so now cancer genetics tends to be where you're going to see most genetic counselors actually practicing. But also in the last 10 years, there have also been in many, many different adult onset conditions, many things that have been going on that there are now genetic counselors that will be in neurology and in cardiology and psychiatry and endocrine, and then there'll be also just general large genetic clinics that will take not only prenatal, pediatric, but also adult patients. Also, what we're seeing in the last couple years is that genetic counselors are also getting into many, many other realms, including pharmacogenomics, as well as paired testing with in cancer, where we look at the tumor itself compared to the germline and try to figure out best treatment options based on genetic mutations. Also, you'll see genetic counselors in industry. There are multiple commercial laboratories that offer genetic testing, and many of them have genetic counselors that work for them. You'll also see them often now, genetic counselors, working at large academic institutions or hospital systems and helping with ordering of genetic tests and laboratory utilization. An awful lot of genetic counselors now work in research, including with the eMERGE project that I think was also just recently mentioned, and also in public health, where I had come from before I went to Northwestern. If you're wondering how to find a genetic counselor, this is actually the National Society of Genetic Counselors website. And if you just type up Find a Genetic Counselor or www.nsgc.org, and then if you click on the in-person, then you can put in your zip code, your state, and then the list of genetic counselors will come up as well as their specialties. This website was just recently updated. It is true that some genetic counseling services now are being actually done just by phone rather than in person with an individual to really help with that access issue. But when I just looked at this updated information, it looks like that National Society of Genetic Counselors needs to do a little bit more refining of that by phone information. So for instance, when I put in Illinois there, genetic counselors came up in New Zealand. So I don't think I want to have a genetic counselor in New Zealand doing phone counseling to patients in Illinois. So just be careful of that. And I would go ahead and just use the in-person one for now. Also, remember how I said that there is this explosion of laboratories as well as genetic tests that have happened in the last 5 years especially? The best resource, because this often comes up as a question, that I can recommend to all of you, to look for laboratories, to look for what the information is about a genetic condition or a specific gene, is called GTR, and it's recently come out. It used to be Gene Reviews or Gene Tests, but it's the Genetic Testing Registry. And if you go on there and you type up any condition or any gene, you can also then look at a whole bunch of other different databases to find out additional information about that. But also, most importantly, you can find out what laboratories in the whole world do testing for that condition and what kind of testing they do. So this is the vision, the current vision of the National Society of Genetic Counselors, and it is to integrate genetics and genomics to improve health for all people. And when I think of that vision, when we think of for all people, that's an awful large vision, because currently in the United States there are 324 million people. As I mentioned, there's only 4,000 genetic counselors, and for us to try to ensure that we have access to all residents based on regardless of their race, gender, income, geography, and ability to pay is a very large task. And one of the things to think about is that possible to be done in all of our hospital settings when there's about 5,600 hospitals with only 4,000 genetic counselors? And the large majority of our hospitals in the United States are community hospitals. And most genetic counselors are employed in academic settings. So we really need to think of brand new ways to deliver health care and new partnerships. And that's why I started to get excited when I thought of public health dentists, because it is another place where you can find and access genetic patients and come up with brand new partnerships that could help perhaps create a wonderful, wonderful partnership. This is something that came out in 2002, and that was right about the time that I started getting into public health genomics, when that term first came about. And this came out as a vision for public health genomics in 2002. And at the time when I read this, I highly doubted it. But now it is very much true. That genomics, it had stated, will be to the 21st century what infectious disease was to the 20th century. And it should be considered in every facet of public health: infectious disease, chronic disease, occupational health, environmental health, in addition to maternal and child health. And I would like to, after learning more about public health dentistry, put out the statement that I think that public health dental professionals should also be added to this list. This is what I had mentioned to you earlier about this explosion of genetic tests that has happened. So currently, and this is as of September when I pulled this off of that former website that I mentioned to you called Gene Test, that's now been replaced by that genetic testing registry, that GTR, that currently there are over 68,000 genetic tests that are currently available. 68,000. But how many of those over 68,000 tests do you think that there is evidence for their use in actual practice? Raise your hand if you think it is all 68,000. Raise your hand if you think it's 10,000. Raise your hand if you think it's 1,000. Okay? Raise your hand if you think it's 500. Raise your hand if you think it's 100. Raise your hand if you think it's 0. Raise your hand if you think it's about 50. So I don't know if those people actually looked ahead, but that is correct. That it is, and I'll get to that slide in just a minute, it is about 50 genes only that we have very strong evidence for use. And when we think about evidence for use in a clinical practice and in a clinical way, and also in a public health way, this was actually being promoted for, the past 15 years by the Centers for Disease Control's Office of Public Health Genomics. And then some people call this the ACE, ACCE model. And the ACE model, why we call it that, is A stands for whenever we think of a genetic test for use in a very specific situation, we want to know about first the A, which is analytic validity, how valid and reliable is that test or service. Then the next thing we want to think about, which is going to become really important for an example I'm going to give you, is clinical validity. That's the first C in ACE. And clinical validity is how well does that test predict outcomes. The next C of ACE is clinical utility, and this is a big one. And so for clinical utility is what are the benefits and harms of that test or service in the patient management? Does it really change patient outcomes? And then the E of ACE that some people refer to, like I said, this model, has to do what are the actual ethical, legal, and social implications of that genetic test or service. So what the Centers for Disease Control and Office of Public Health Genomics has actually done is they've looked at a fair number of genetic tests and tried to put them into categories, thinking about that ACE and thinking about tiers of evidence. And if a genetic test for a very specific population has very strong evidence in all of those ACCE categories, and if we believe it will have a large population health impact, that becomes a test that we call a Tier 1 test. If a test is known to potentially cause harm for a population because either a lack of evidence or we have evidence of actual harm, that is called a Tier 3 test. And if it's a test that we just don't have all the answers to, those ACCE categories, that is called a Tier 2 test. And as you can see, some of the criteria they look at when they think about Tier 1 tests is, does the FDA label require that test to inform the choice of a drug or the dose of a drug? Does Medicare and Medicaid cover that test? And are there clinical practice guidelines based on systematic reviews that support that testing? And then examples in the Tier 3 category would be when FDA labels caution against that use, when CMS has said that that test should not be done, or when clinical practice guidelines recommend that it should not be done. And you can see that the Tier 2 is basically when there's just an awful lot of uncertainty going on. So when CDC's Office of Public Health Genomics has looked at those Tier 1 tests, once again, there has to be proven analytic validity, clinical utility, it has to be known to save lives. And as I mentioned before, which those that raised your hand, good job, there are only about 50 tests that meet all that criteria. And of those 50 tests, the majority are related to cancer. And they're not just related to hereditary cancers, they could be related to pharmacogenomics or treatment of cancer. And so not only can they have important implications for diagnosis, but also for prognosis, risk prediction, treatment, and screening. Also, 2 of those very specific genetic tests, in 2010, we knew already at that point that there was enough evidence that they were very strongly in that Tier 1 category and that we should be promoting it for very specific populations. And it rose to the level of being Healthy People 2020 objectives. So since 2010, both of these are the only genomics objectives that have been so far approved by Healthy People. We'll have to see what happens in Healthy People 2020 if there's more. But these 2 are important for everyone in this room to know about. The first one is that for adult women that have a significant family history of breast and or ovarian cancer, that they should be referred for genetic counseling and consideration of BRCA testing. And BRCA testing, that's the gene that Angelina Jolie, for instance, has. And that is also something that in 2005 and again in 2013 is a grade B United States Preventive Service Task Force recommendation. And since it's a grade B USPSTF recommendation, that is something that is covered under the Affordable Care Act as well for preventive services for adult women. So for adult women who have a significant family history, not everyone, just if there's a significant family history, they can be referred for genetic counseling and BRCA testing. And that is also, like I said, covered under the Affordable Care Act. The second Healthy People 2020 objective is that all individuals that are newly diagnosed with colorectal cancer should be screened, and it's their tumor that it starts on, for hereditary colorectal cancers, especially one called Lynch syndrome. And Lynch syndrome confers up to 80% risk for colorectal cancer, as well as risk for ovarian cancer, endometrial cancers, and a variety of other cancers. Lynch syndrome also is a dominant condition, so once an individual has been diagnosed with that, all of their immediate family members have a 1 in 2 chance or 50% risk for that, and that is where the evidence for the use of this test comes, is for saving the lives of those unaffected immediate relatives by finding out that their immediate relatives has Lynch syndrome. They then have it screening and being able to prevent cancer from occurring in those very high-risk individuals then that have hereditary colorectal cancer. And we're going to talk about some other ones that are different than Lynch syndrome, but that also have very important craniofacial and oral health findings. And that was not based on a United States Preventive Service Task Force guideline. That Lynch syndrome guideline or hereditary colorectal cancer guideline is based on another guideline that came out of the Centers for Disease Control, something called EGAP. And EGAP is like the USPSTF, but it's specifically looking at genetic tests for their use. And to date, there has only been one EGAP recommendation that has come out that there is sufficient evidence for its use in a population, and it's the one I just told you about. Every other one that has come out has said there is insufficient evidence, and it's falling in those Tier 2 recommendations. As I mentioned, that USPSTF recommendation, that grade B one. Also, both the BRCA and the Lynch syndrome recommendation, when I was trying to think of public health dentists, certainly that has somewhat implications, but I really wanted to come up with some thoughts for you all that have really, really actionable thoughts and ideas that could happen in a public health dental office on Monday. So what came out is this came out in 2016. I know there's been a lot of talk that I've heard this morning about whole exome sequencing, whole genome sequencing, and when those results come back, you now have a whole slew of information about a person, but what type of information do we have evidence that we should definitely give back to that person and return to that person because it's known to save lives, and that we have the start of some of that good clinical evidence both in that ACE information. And so the American College of Medical Genetics in 2016 updated this list, and they came out with 59, and these are really important for the people in this room if you're not familiar with these guidelines, and if they have not come out, please pull them up. But there's 59 genes that they say if you find, and even if there's no, like you were doing the testing for other reasons and you were doing it under a research protocol or you were doing it for clinical reasons, you were doing whole exome, whole genome sequencing, and you were doing it for something completely different, if you find any of these 59 genes, they would be very, very important to report back to that patient because it could save their life. And when I started to look at these genes, about half have very important implications for everyone in this room, I believe. And I could not find this ever reported, and when I came across this, it was a big aha moment. So it might be something that someone in this room would like to publish on too. But this is the start of what could be a publication for somebody in this room. So if you look at those 59 genes, when I started to look at just some of them, and started to pull out ones that had big implications for everyone in this room, there is a list, and many of them do have to do with hereditary colorectal cancers, that could be extremely important to be looking for. And I'm going to give you the example of the first one, which is called FAP. There are other ones on here like Peutz-Jeghers, Cowden syndrome, which are also hereditary cancers. There's also ones that are related to sudden cardiac death. that are also dominant conditions, like something called long QT syndrome, also malignant hyperthermia, which can be really important for treatment when you're thinking about things that could happen in a dental setting with both long QT syndrome and malignant hyperthermia that could possibly lead to death. There's also Brugada syndrome, which is another cardiac condition as well. And if anybody wants to contact me, please feel free to, because I do see some people writing quite a bit down here, and I do not mind talking this through with you. So this is FAP. How many people in this room have ever heard of FAP? Has anyone? Okay. So FAP is the second most common hereditary colorectal cancer, behind the first being Lynch syndrome. It happens in about 1% of all colorectal cancers that you find FAP. It is a dominant condition, so once again, your immediate relatives would have a 50% risk of having it. But in anyone that has this gene, this is very different than most hereditary cancers. There is a 100% chance of penetrance, meaning that if you have that gene, there is a 100% chance that you will develop cancer. That is not the case for any other hereditary cancer that I can think of. Most of them have a reduced penetrance, we call it. And if it is untreated, 100% of the time it will develop into polyps with a very significant risk for cancer. And there's a very significant risk for other kinds of tumors beyond those that would be in the colon. And this is an example down there of what the colon can look like. And you're seeing a blanket of over 100 different polyps. So that's what that is on the bottom. We are talking about a lot of polyps going on with FAP. Also, you can see other kinds of cancers, including thyroid cancers, brain tumors. You also, importantly, can get jaw osteomas. You also can see dental anomalies as well. You can see extra teeth. You can see unerupted teeth. You can see congenital absence of one or more teeth. And whenever you've looked at FAP information, for many years it's been described, you always will see those teeth anomalies that are being described with those, with FAP that happen in about 1 in 4 to 1 in 10 individuals. So if you see those dental anomalies, or if you see that somebody has an osteoma of the jawline, what should be the next question out of your mouth? Anyone want to take a stab? Let's see if we got you up after. So think about the next slide. What's the next picture on there? So what, if you see any of those two things, what should be the next question? Does anyone want to take a stab? To ask about an area would be your colon. But to ask, have you had a colonoscopy done? Is there a family history of colon cancer in the family? If the answer is yes, then I would say to the person, have you seen genetics? If they say no, then I would say, let's talk about you seeing genetics. Because this is extremely important, and the vast majority of people that have FAP have never been diagnosed. And if you find it, there is treatment available that we know can save lives. And once again, that is one of those examples of a gene. Okay, so now I'm gonna switch a little bit and switch from my genetic counseling hat, which I can never remove, more into my public health hat. In Centers for Disease Control, as was mentioned, in public health genomics, I had worked in that realm since 2003 up until just August, and so it is where my comfort level is, but genetic counseling is actually where my foundation is too, so you can ask me questions about either area. But a lot of that thinking that I just mentioned to you that comes from my clinical genetic counseling background is what has formulated what we think of public health genomics and state health departments now. So when we think of what state health departments are doing in the area of public health genomics and what they're funded to do right now, really have to do with the 3 core public health functions of assessment, policy development, and assurance. And this is what the Centers for Disease Control is currently funding 5 states in the United States to do, which are the states of Michigan, Utah, Oregon, Connecticut, and Colorado. So if you're from any of those 5 states and you want to know more about who is in your state health department that's working on this topic, please just let me know and I can get you in contact with them. But what is happening in those state public health realms is they're thinking about assessment and making sure that there's more precision in actually measuring population health problems. And I'm going to show you more about that. We're also in state public health departments thinking about policy development and developing the right intervention for the right population, and also promoting that at a policy level, not only with laws, but also with policies and health plans, policies and health systems. Also thinking about assurance and making sure that there's more precision in actually delivering interventions and addressing health disparities. Also, we're thinking about this too, not only in state health departments, but also at a national level with the National Academy of Medicine, who just in 2016 formulated a work group that I'm going to tell you this is a unique opportunity for anyone in this room that would like to join forces with us and become part of the National Academy of Medicine, which usually requires a long appointed process. This is a unique opportunity that I'm telling you it's open to anyone in this room. So just let me know if you want to be part of a National Academy of Medicine committee that's called the Action Collaborative on Genomics and Population Health. And what our Action Collaborative is trying to do is really think about many of those genes that I mentioned to you and thinking about really that policy development, thinking about assurance, thinking about assessment, and really thinking about implementation. Also a bit about learning health systems. So many of the people that were on that paper that was just presented about learning health systems and precision medicine, David Chambers is the one that authored it. He is one of my co-chairs on this committee. Also, Meween Curry is on here as well. And right now, we have been focused in the past year about state health departments, but now we're moving into the thinking about what should be being done for precision medicine, both between state health departments as well as integrated health systems, like Kaiser Permanente, Geisinger, Intermountain, and then probably we're going to move into more other health systems and community settings in the coming years. I can tell you there is not one public health dentist in my whole GPAC, we call it GPAC, or our whole entire Action Collaborative, and I would love to have some involvement. So please, if you're interested, just let me know. And in the first year of our development, we really, as I mentioned, we're focused on state health departments and what are state health departments doing in the area of public health genomics, not only those ones that are the 5 funded states, but across all 50 states, what is happening. And so when we looked at that, we actually also thought about what are the current states that are doing something, what is their objectives, what are their measures that they're using, and a paper just came out this month that is actually the first paper that's been published from our Action Collaborative, but there's a lot more in the pipeline, and it was in genetics and medicine. We also not only are focused on implementation and what's happening in state health departments as well as in health systems, but also the thinking about what is happening at a population level. And that's been another definitely work group that just developed in the last year. There's also the thinking about what should happen once you find an individual that has one of these conditions and what we call cascade screening to their unaffected relatives. Like I mentioned to you, like what happens with that Lynch syndrome recommendation. So there's a group that's working on that as well. So if you're interested in learning anything more about it, just let me know. As I mentioned, this group, this Action Collaborative under National Academy of Medicine involves many different kinds of stakeholders. I think there's now over several hundred people that are involved with this Action Collaborative, and I would love to add to this diagram public health, oral health, or dental organizations. And then I truly believe that this statement that came out in 2005 is very, very true. And that's why I'm definitely asking all of you to think about joining us, because I don't think any important health problem will be solved just in the clinical care setting alone. But I do truly believe that it takes multiple sectors, both public and private sectors, working together. And when it comes to thinking about something like precision medicine, oh my goodness, the more people we have around the table will just make, I think, things make sense in a lot more ways, shapes, and forms. As I mentioned, the Centers for Disease Control does currently fund 5 states. They have been funding states, though, since 2003 to do work in the area of public health genomics, and I'm very blessed to tell you that Michigan, that we have had funding, and as was said in the introduction, for at least 5 different, some are not all on here, CDC cooperative agreements, of which I led. So I'm going to give you some of those activities, although there are many, many more activities, but I'm going to just give you some highlights of some of the state activities to give you some ideas of what could be happening that could also build bridges with what's happening in state health departments and genomics, as well as in oral health programs. But what had happened in about 2 years ago is the Centers for Disease Control and National Institute of Health and the leading organization called Genetic Alliance for Genetic Support Group said, we have to get out to other state health departments how to do this work. So they created a video that includes Francis Collins, as well as many of our partners in Michigan, including this individual, this young woman who was one of our champions, who actually has a BRCA mutation, and her daughters have been tested for that as well. And we also came up with a plan of what people in state health departments that are thinking about genomics should actually do to create a program. And one of the first things had to do with setting goals and looking at available resources. And how we do that did that in the state of Michigan, and currently they're doing it in the state of Michigan, is what the first step often has to do with thinking about state plans. And state plans is often a very good way to engage multiple partners to integrate precision medicine or genomic findings. And I'm very proud to say that this is the second time, but it also started in 2009, that in Michigan, we not only have a specific goal about public health genomics, but strategies and objectives that all of our partners, and there's over 120 different cancer organizations in the state of Michigan all working on those goals related to genomics. And I know Michigan was kind of unique when that first started in 2009, but I can tell you because of that, and us following this now, gosh, I've been following states' cancer plans for, since 2005. When I started in 2005 looking at state cancer plans, it was less than a third of state cancer plans that even had the term genetics anywhere mentioned in their state plan. But now I can tell you the vast majority, over 90% of state cancer plans have words related to genetics in their state cancer plans. Often they have actually objectives and goals and strategies related to it. And this just shows, for instance, if you're in a state that is of the orangish reddish color, they actually have goals and objectives and strategies all related to those Healthy People 2020 objectives. If it's in a blue state, like here in Texas, they just have a term related to genetics. They don't have a goal or objective or strategy yet related to that. If it's a green one, they have at least one genomics-related goal, objective, or strategy, but it might not encompass both of those Healthy People 2020 objectives. So because I don't know much about state oral health plans, I've been looking at them over the last 3 weeks or so. And I've been trying to find if there is any state oral health plan that has any term or objective or strategy, and I'm seeing people's nodding of their heads what I thought the answer was, and I think it's like what cancer was even before 2005. I could not find one, not one. But like I said, I did not take a thorough review of all 50, but I tried to look like just by glancing through things and doing Google searches. So that might be a really interesting place to start, is thinking about if you were going to draft something for your state, and I can tell you for those that work in a state health department and for you that don't work in a state health department, state health departments, when they're doing their state plans, love to have as many partners coming to the table as possible. And if for your state you came together and said, gosh, I think we need something about precision medicine in our oral health plan, what could that look like? And what could be a goal? What could be an objective? What could be a strategy? And I can tell you, once there's a good one out there, other states hear about that, and within 5-6 years, you're going to see that in a lot of different areas. So I can't tell you what pleasure it gives me to see something that we had drafted in Michigan in 2009 now being in the vast majority of all state cancer plans in less than a 10-year period of time. So that might be one place to start. When I started to think about what already exists that could be put into public health practice and could be really important for clinicians and could start to be something that a state oral health plan would want to incorporate, I was pleasantly surprised to see that this October, the American Dental Association came out with a whole module about genetics and oral health. And they came out with 3 key points, or actually 4. And these 4 key points I completely agree with. So if any of you were involved with drafting this educational module or these 4 key points, please come talk to me because I would love to give you a high five. This is like perfect, perfect. So if all oral state health plans had this language, oh my gosh, it would be just amazing. And like I said, I can't find one that has anything even close to this. But number 1, they said, is that many common diseases are inherited in a single gene defect, are not inherited, in a single gene defect, but instead result from gene-environment interactions. Very, very important point. Number 2, and this is going to be really important as well, a predictive test for dental caries or periodontal disease does not currently exist. Both of these are complex diseases with multiple gene and environmental risk factors. Very, very true. And that's going to become really important here in a minute. Number 3, No gene to date has been identified that has a large impact on periodontal disease, as do environmental influences, such as smoking or diabetes. True. Number 4, while genetic testing holds potential for clinical application in the future, clinical measurements remain the best approach to assessment of caries and periodontal disease at this time. Do you know why this was so very, very important? Because of something that actually I didn't know despite being in Michigan when this happened. And I have now reached out to quite a number of people in the Michigan area, and it sounds like this was something happening in the dental community that us in public health and us in clinical genetics and even the public health people, the School of Public Health folks, did not know this was going on either. And that I've all just been doing a little bit of background investigation over the past week or so. But very much, I think people in this room may know this is what happened. And this is why this is so important, what we've been talking about. There was a test that was created for a gene, 4 genes actually, called interleukin-1b. It has been in some studies associated with inflammatory diseases. And there was also a test that then became available commercially that said it could help predict periodontal disease. That became then commercially available. And as I understand it, it also became something that Delta Dental of Michigan required of certain kinds of insurance policyholders, including, and I'm getting some nods of heads, so maybe you know some more information about this, including if you were an employee of Amway, for instance. And Amway, so I just moved from Grand Rapids, Michigan, that's based in Grand Rapids. I can tell you they are one of the very biggest employers, if not the biggest one, in all the Grand Rapids area. So if you had Amway insurance through Delta Dental of Michigan, then you were required to have this genetic test to then see if you were at high risk to be able to have more than just one annual cleaning. And so it was being used for policy development. It was something that was put into not only clinical practice, but a requirement within policy for a test that when we think of Tier 1, Tier 2, Tier 3, that's a test that falls in Tier 2. It clearly does not have clinical validity. So this is an example, yet proven, and maybe it will one day, but not right now, and it is certainly not something that should be implemented into a whole entire population. That takes an incredible amount of evidence to jump up into that Tier 1 category. So this is a really important example of something that maybe would be something to think about from both a public health perspective, health disparities perspective, genetics perspective, public health dental perspective that really needs to be promoted above and beyond just the American Dental Association, who came out then in October as well, not only with those educational modules that very clearly have those 4 important educational points to it, but a very strong policy statement as well. So I would say kudos to the American Dental Association for actually coming out with this policy, because I completely agree with it, and it's perhaps one of the best examples now I have of what happens when a test is in Tier 2 and then somebody decides it's got to be over in Tier 1 when it's not ready. Not ready. Okay, does anyone else want to add to that story? Okay. So this is an example of how things move from genetic discovery into translation. So most of the thinking that has been done in genetics has happened in what we call this T0, T1 stage, which is in that gene discovery stage. But not an awful lot of work has yet been done with trying to think about if those genes have enough evidence base for practice in actually the clinical setting or in the policy setting. And that's where more work has to be done, which is why we have created that National Academy of Medicine implementation work group that I mentioned to you. And there's been a really great paper that's been published about this from the National Cancer Institute that states that actually most of the genomics publications that are out there, 98% of them are actually in that T0 to T1, that gene discovery stage, and less than 2% are actually in that more implementation stage. So there's a lot of work that needs to be done here so that we don't have things happen that happen prematurely. Okay, I'm going to give you also some other quick examples from state health department work. I'm going to go through these quickly. So as I mentioned to you, one of the things that we do in health departments that are funded by CDC is we do policy work. And in the state of Michigan, gosh, starting in 2007, we started working with health plans to promote best practices for cancer genomics and looking at their policies and saying what of these seems to be the best one to promote to other health plans. Kind of like that same thinking with the state cancer plans. If you find one good one, then you can promote it to all. And that was the thinking of it. So what we did is not only tried to look at, in the state of Michigan, there's 25 major health plans. We looked at all 25 major health plans, their policies for that grade B BRCA recommendation, as well as the Lynch syndrome recommendation. And ones that had really good policies, we honored those, we gave them awards. And those that did not yet have a good existing policy, we tried to encourage them to look at other model examples. We also used data to really show each health plan, and this is data that we had collected since 2008 that now includes over 20,000 individuals that have had genetic counseling and may or may not have had testing for the BRCA gene. And what we wanted to try to show health plans is if they had enough patients or members rather that had been seen by genetic counselors, were they meeting that Healthy People 2020 objective? And were we seeing that they were increasing that the number of adult women that were being referred for genetic counseling? Any health plan that we could look at, we found that they were definitely meeting that Healthy People 2020 objective. But there were a number of health plans that we had not found had referred any genetic counselor or had no member that had had genetic counseling. And those tended to be always the ones that didn't have a policy either. So when we did this, when we first started the work in 2009 and had our baseline, there were only 4 health plans of the 25 that had a really good policy. And by the time that I had left the state health department, I'm very, very proud to say that it was now up to 18, covering almost the vast majority, 90% of our 10 million residents in the state of Michigan. And so when I was looking for things related to public health dentistry, I came across United Healthcare's policy. And United Healthcare actually does have a policy regarding genetic testing for oral disease that very much seems to embody what is the American Dental Association's policy, that there is not currently a test available that they would cover for periodontal disease. Also, one area to thinking about as well is in genetics. We definitely know that if people are in rural areas, like in the thumb of Michigan, there is no genetic counselor there is no specialist that's an oncologist, but yet when we look at the colorectal cancer incidence and mortality in the state of Michigan, and ovarian cancer, which is another really important cancer to be concerned about for hereditary cancers, the highest mortality and incidence in the state of Michigan, when we look at county data, age-adjusted, is in that thumb of Michigan. So when we think about that thumb of Michigan and how to get people to genetic services, we had reached out to 11 different primary care providers that do all of the care for that whole thumb of Michigan. But then when I thought, putting this talk together, it might be really interesting to talk to dental folks there too, in that thumb of Michigan, and another way to reach people. Also, I think, just to let you know that there is, Joe Biden had put together, when he was still in office as our vice president, something called the MOONSHOT project to try and advance cancer research. And when they looked at the best way to where to put thoughts and funds into for prevention, what came out, which was a surprise to us, because other things that were on that list were HPV vaccinations, tobacco control, was actually the importance of genomics and really promoting this screening for the detection of hereditary cancers and preventing cancers. So that is where actually funding came out, and that the RFAs were actually due 2 weeks ago or so. So I think there will be 5 different projects that are funded under this MOONSHOT project, so it'll be interesting to see what comes of that. And then the thing that I'm going to end on is I want to encourage everyone to think about, because this is very much a public health genomics application, even though it does not involve any genetic test, is just your family history alone. Your family history alone is a very perfect reflection of the genes, environment, and behaviors. And by looking at a family history, you can tell an incredible amount about people. And so the United States Surgeon General, since 2004, has created this electronic tool called My Family Health Portrait. It's very much promoted around Thanksgiving time, but I would tell you to think about it at all times, and it's a way that you can collect information, or your patients can, and it actually draws out pedigrees and whatnot for you as well, and it can be shared with providers. And with that, I would like to thank everyone for your attention.
Well, Well, thank you so much for this great presentation. I really learned a lot. You've been through a lot and so many details, but I think at least for me, the biggest message is the genomics and counseling of genomics. I would say how to market that. I mean, at least myself, there is no way to know how to approach those, professionals, and how for the lay person to know about them, how we can basically, propose that to the public and really, emphasize the importance of that specifically for people who have really risk of, developing several diseases. The other thing that I really liked a lot, that you mentioned something that's really basic in public health that we usually forget about when we go over and try to add something on our knowledge. It's the basic roles of public health, the assessment, policy development, and assurance. I think if we just keep that in mind all the time, and just we fill in the gaps for the new additives that we are trying to, reach, because we usually forget about the basics and go beyond, but we are trying to understand. Thank you so much.
Thank you so much. I completely agree with you. So when I was first learning about public health and came across those 3 core public health functions, I became convinced that that was the way that any activity I was doing, I had to be using all those 3 core public health functions, because it's not only the most effective, but the most sustainable. And I am convinced that that is why we were so successful with getting continual CDC funding and new awards right after one another, is by really using data to then think about policies, and also to promote policies, as well as to think about insurance and trying to use all 3 core public health functions around anything. And I think that's another really, really important message that needs to get out to public health professionals and to individuals that are doing precision medicine, is don't lose that foundation, because when you put stuff in just one area, that's where things are gonna perhaps not sustain themselves and not be very effective. And I completely and utterly agree with you about the need for maybe better branding or more promotion, or maybe better partnerships with genetic counseling, and to try to get that out, which is why I made the switch after a lot of long time thoughts and energies in about switching from public health, which I loved, into now academia and training the future generation of genetic counselors with that mind thinking. So you and I are cut from the same cloth, I think. Yes. Yes.
Thank you for an excellent presentation, and I'm very happy that the dental public health field is being enriched and probably, as you said, the forefront of including genomics, and I think it will move with high speed forward. I'd like to add some more information about the interleukin-1 beta story.
Oh, good, please.
With a little bit more methodological aspects for those who of us are studying this here. The first data, and probably others here around me have more information, emerged from candidate gene studies back in the 90s and early 2000s, where people looked for specific genes and thought, well, there's a good likelihood that there's something there. And there was a body of evidence that accumulated showing that this is there and probably is paired with a plausible story as well. Later on, when the agnostic studies, these GWAS, started emerging, interleukin-1 beta didn't show anything really. So, and my group was one of the groups that actually published that first GWAS where we didn't see anything. And that, of course, was left in the literature for a couple of years until an influential paper appeared promoting interleukin-1 beta as, look, here you should take action. And the wonderful thing that made me proud for our field was that there was actually a data sharing process that took place. So these investigators were asked to provide their primary data, which they were reanalyzed and corrected in a way, or interpreted in a correct way. And that paper actually was accompanied by an editorial by John Ioannidis, who is one of the gurus of evidence-based medicine in JADA. And Ioannidis cited the GWAS, and they said, look, if you look at the whole genome, it's nowhere near anything this. So overall, I think the process was cathartic in a way for the field, was very educational. Now we see less and less of these candidate gene studies from small samples that show surprising results, but in the large scale of things, they tend to be most likely false positives. And actually the taste genes, the question that was asked earlier, emerged from a sample of about 500 children of mean age 3, where you would wonder whether taste preference determines their diet or is their parents who do it. So it's one of these candidate gene studies that, of course, is very easy to, it's attractive as a message, but on the long run, when we have more agnostic studies, these candidate gene studies tend to usually not replicate.
Thank you so much. So I had just, so what you just said, I had just read this week for many of those things that you mentioned. And when, for our Northwestern Genetic Counseling Program, we have 40 students now, which is the second biggest actually in the nation. We've quite a number of students, and 40 might be surprising to you all, but that's actually a lot for a genetic counseling program. And so I teach the research methods class. And I have really good examples of every part that you mentioned there about when you get to GWAS, how things can sometimes come apart. And also when data gets looked at one way and then now data sharing agreements and trying to make sure things are replicable, you can sometimes have things that come out that are very, very different as well. And there needs to always be an awful lot of time, energy, and thought before we say something is ready for a population use. But I never had an example until now that showed all of those parts with one different specific gene discovery that then ended up with highlighting every single part. So I can tell you at University of Michigan, the School of Public Health there, who's in charge of their public health genomics program, he said the same thing. He was not aware of it till this week, till I sent it to him. And this is an amazing, but not the greatest way that you want to find something like this out. But for public health students, as well as genetic students, as well as many medical students and others, it's a very, very good example of that whole genomics translational pathway and really making sure everything is in place before you put something into policy. It is a very good example. So please, I would encourage you, I am going to be using this example in my classes and teaching and to genetics audiences. I think it needs to get out much more widely because I can tell you in realms that people should know this, we did not know this was going on, and we should have. And that when I was reading more about it, it sounded like that a lot of times things were falling on deaf ears, and that should not have been the case in this whole situation. And it is a very, very important story.
Another kind of question.
Yeah.
Our lab identified, cloned, sequenced, mapped a gene that is the dominant gene in enamel, in tooth enamel. And when there is a defect, which we identified and so forth, it's called amelogenesis imperfecta.
Yes.
The employment of that assay, it's also uniquely found on both the X and Y chromosome, so it can also be used for identifying, especially in forensics, the difference between a male and a female bone or skeleton in terms of anthropology. However, anthropologists have picked it up, but surprisingly, dentists do not use this. Explain, from your point of view, what are the opportunities and challenges for implementation of scientific discoveries?
Oh, thank you. That is a great question. Well, kudos to you for that gene discovery. That in genetics realms is a major gene that we often learn about and is now I can say I've met the person who discovered that, so that's wonderful. So I think this is an example of what happens in genomics translation and implementation when you don't have multiple sectors all working together and really thinking about, once again, a basic public health principle, bringing many, many sectors of the different kinds of stakeholders together to promote messages. And so when something happens in which you can see in the anthropology world why that would be so important is when that got translated into the anthropology world, how did that happen? But why hasn't this been brought to the table for other people to think about? And it would be something I would say to CDC in their oral health people, like, why don't we think about what genes do you think are perhaps good to bring this group of multiple kinds of stakeholders together to say, let's do some thinking about, is this ready for prime time, or is this ready for clinical applications? Do you see uses of this? What could be the possible barriers of it? And really start building those bridges within CDC or HRSA, because there's a lot of genetics people over in HRSA that deal with newborn screening, for instance, and birth defects prevention. Bring these hats together and really think, like when we think of oral health implications and the genes that we know exist, because there are a lot, what do we think is ready that we really want to put multiple people around together to really think about how to move that farther down the translational pathway? Yeah, so this is one of the thinkings of the Institute of Medicine or National Academy of Medicine. It's the population screening work group that's being led by Jim Evans. He's from North Carolina. He's also the editor of Genetics in Medicine, and really thinking about what genes are ready for that population screening. So maybe it even goes under that umbrella, and to try and pique their interest in, like, let's think about, these genes that have to do more with dentistry and dental and oral health, and thinking about putting that on the list too. Because I'm sure when those ACMG 59 genes, I'm sure there was nobody like you there at the table that has made a major gene discovery, and maybe you should have been there at the table. So we just need to build those bridges. Yeah.